identification of the late onset hypogonadism in middle-aged men. Patient may come with varying complaints. This you can get either in station 2, that is a history taking, or in the station 5 as a brief consultation. So patient has got vague complaints, lethargy, fatigue, and sexual abnormalities. So you have to suspect a late onset hypogonadism in middle-aged men. So you have to ask for 3 sexual symptoms. So you can ask with the permission of the examiner, what is the frequency of the morning erection? All of you have the morning erection. So you can ask the frequency of the morning erection, the frequency of the sexual thoughts, and erectile dysfunction. These are the 3 sexual symptoms you should ask the patient. Okay? How frequently you get the morning erection? How frequently you have the sexual thoughts? And do you have any erectile dysfunction like premature ejaculation or erection abnormalities? So these 3 sexual symptoms you should ask. And then the physical symptoms. Are you able to inability to participate in strenuous activities like jogging and exercises, strenuous exercises, inability to walk more than 1 kilometer, and inability to bend, kneel, or stoop. So these are the common physical activities will be affected if the patient has got a hypogonadism. Okay, inability to participate in strenuous activities, inability to walk more than 1 kilometer without difficulty, and inability to bend and kneel and stoop. Some things fell down. He is very lazy to bend down and take the things. These are the 3 physical symptoms you should always remember. And then psychological symptoms. Feeling of tiredness and sadness, loss of energy. You always feel I am very tired, and easy fatigability. You start doing something, but you are getting fatigued. So these are the 3 psychological symptoms you should ask in the late onset hypogonadism. Now comes the thyromegaly. You will always get a patient with a thyroid enlargement. So you start with a focused history. In the station 5 especially, you start with a focused history. Okay, the presenting complaints and duration of the symptoms. And then history pertaining to thyroid status you should ask. History of palpitation, history of any altered bowel habits, any appetite changes, any weight changes, any cold and heat intolerance, any mood changes, and sleep pattern of the patient. These are the common symptoms pertaining to thyroid status you have to ask in the clinical history elicitation. Palpitation, altered bowel habits, appetite changes, weight changes, cold and heat intolerance, mood changes, and sleep pattern. And then if a female, you can ask about the menstrual periods. Okay, and also difficulty in getting out of the sitting posture. Sometimes they will have a proximal myopathy, difficulty in combing hairs because they cannot raise the limbs above the head, whether they have any diplopia, and whether they have any blurring of vision. These all symptoms should come in the history taking of a thyromegaly. Then start examining while taking the history. Okay, then make sure that you will always be, not you sit here. You make sure always you look for a glass of water. Please look around for a glass of water. All the thyroid cases, we are keeping a glass of water. And without that, it will not be there. And even if the examiners have forgotten, you can ask the examiner, please get me a glass of water. And the glass of water, you ask them to keep it in the mouth. And when you tell him, ask him to swallow. And when swallowing, you look the thyroid swelling. How does it move? Whether it is moving with deglutition or not, and what is the texture, what is the surface of the thyroid movement, you can observe while doing the drinking process. Okay, and once you have given the water, then you can go behind and repeat the same thing, standing behind him like this. Repeat the same thing. Ask him to swallow and then feel the thyroid gland. Okay, at the same time, once you finish from behind, you can finish looking for the lymph nodes. Okay, and at the same time, from here, you can look for the exophthalmos. Okay, is there any exophthalmos? So all these can be finished from behind. So you start with a friend, ask him to swallow some water, look for the thyroid movement and the thyroid swelling. Then you come back and confirm your finding with the palpation from behind while swallowing the water, and then look for the lymph nodes, any lymphadenopathy, and then look for the exophthalmos from here, and then come to the friend, start assessing the thyroid status as though you are shaking hand with him, and look for the sweaty palms. Okay, and look at the pulse for 15 seconds, and then look at the outstretched hands. Okay, for the tremor, And at the same time, you look whether the patient has a thyroid acropathy by the finger clubbing. Okay, and then when finished, then you go to the leg and ask him to raise it and look for the pretibial mixed edema. Okay, these are the things which you should finish to assess the thyroid enlargement. Okay, so this, don't forget to look from the behind. That is always better to look from behind. Okay. Then you have looked for the lymph nodes. You have looked for the exophthalmos, and then you are assessed the thyroid status. Okay. Palpate for the sweaty palms. Look at the pulse for 15 seconds. Look for the tremor. Look at the hand for thyroid acropathy. If appropriate, look for the carpal tunnel. If you suspect a hypothyroidism, then you look at the carpal tunnel. Also, ask the patient to raise the hands above, so that you can look for both whether the patient has got a proximal myopathy and a Pemberton sign. Pemberton sign means when there is a retrosternal extension of the thyroid, the elevation of the hands will produce a fusion of the conjunctiva and the face. That's Pemberton sign, which will give you an idea about the retrosternal extension of the thyroid. And look for pretibial mixed edema. Okay. And then look for the thyroid eye signs. Okay. If the thyroid eye disease is present, you should assess the activity by the following methods. Ask the patient whether he has any retrobulbar pain, any spontaneous pain, pain at rest, whether he has. Second, whether he has any pain while moving the eye. That is very important. And then, so look at the eyelid for the redness of the eyelid, redness of the conjunctiva, swelling of the eyelid, swelling of the caruncle, swelling of the conjunctiva or chemosis. These things you should look for. So you ask for the pain, whether you have any pain on eye movement. This is very important. If the patient has got an exophthalmic thyroid eye disease, signs are there, always you ask the patient whether you have any pain while moving the eye. Why? Because you are not going to look for the lid lag. You are not going to cause inconvenience to the patient. If you have severe pain while moving the eye, you do not have to look for the lid lag. Lid lag is one of the signs of the eye disease, no? So the pain symptom is very important. In station 5, you ask the patient, do you have any pain while moving the eye? If they say, yes, I have pain, then you can tell the examiner, I am not looking for the lid lag because the patient has got a spontaneous retrobulbar pain because of the active eye disease. Okay? So don't forget to ask the patient whether he has any pain, because some of the endocrinologists as examiners, they may fail you if you do the lid lag without asking whether the patient has pain. So remember that, okay? So you ask for the pain, if there is, whether the patient has got a retrobulbar pain or pain on movement of the eye. This is very important, spontaneous pain or pain on eye movement, okay? These two you have to make sure, and if there isn't have, then you look for the redness of the eyelids, redness of the conjunctiva, okay? Swelling of the eyelid, swelling of the caruncle, caruncle is here, and then swelling of the conjunctiva or the chemosis, you can look at the conjunctiva. These are the signs of an eye disease which you should look for. Now, look at the cornea, whether the patient has got any corneal involvement, and also look to see whether the patient has got a lid retraction, and then look for the lid lag. If the patient has no pain, ask him to look down very fast, okay? That is the lid lag, and that only you do it if the patient does not have any pain. And then look for the ophthalmoplegia. Ask the patient to follow your fingers, and even if the eye movement is full, at the extreme you ask, are you seeing single or double? Now you are seeing single or double? Single, okay. So that you should ask at the extremes of lateral gaze if the movement is normal also, because patient have a diplopia and an incipient ophthalmoplegia even if the movement is normal. So that is very important. So ask for the diplopia while looking for the eye movements. And you can see a diagram. This is an active thyroid eye disease. You can see the edema of the eye upper lid, edema of the redness of the eyelid, redness of the conjunctiva, then the hypertrophy of the caruncle, and also the chemosis is there. So this is a active thyroid eye disease. Now, how will you assess the activity score of the thyroid eye disease? Ask the patient whether he has any spontaneous retrobulbar pain, pain with eye movement, then redness of the eyelids, redness of the conjunctiva, swelling of the eyelid, swelling of the caruncle, and swelling of the conjunctiva. Or if this is present, the score ranges from 0 to 7. 0 to 2 means inactive disease. Suppose 3 to 7 is active eye disease. Okay? If the patient has got an active eye disease, why do you want to know whether the patient has got an active eye disease? Suppose if the patient has got thyrotoxicosis and an active eye disease, you will not send the patient for I-131 therapy because sometimes it can worsen the eye signs. Suppose if there is no other treatment option, then what will you do? If blurring, then suppose, and also ask for the blurring of the vision. If the blurring of the vision is present, that's a very, very catastrophic complication of the thyroid eye disease called dysthyroid optic neuropathy. Dysthyroid optic neuropathy, secondary to compression of the optic nerve at the apex of the orbit because of the apical crowding of the external ocular muscles. Okay, that's a very dreaded complication. The patient can lose complete vision if you don't treat properly. So if the patient is complaining of blurring of the vision in a thyroid eye disease, it's an emergency situation. You have to assess whether the patient has got a dysthyroid optic neuropathy. And if the time permits, you would like to look for the following: acuity of vision, color vision, and fundus of the disc. And if the patient has got a dysthyroid optic neuropathy, acuity of vision may or may not be reduced depending upon the fibers involved. Color vision definitely will be impaired, and fundus will show the disc swelling. So if these signs are there, the patient has got a dysthyroid optic neuropathy. He has to be subjected to a CT scanning of the skull and orbit to see the apical part of the orbit, to see whether there is an apical crowding. Okay, and that is included in the investigation of a patient with thyroid eye disease. CT of the orbit is included in the investigation of a patient with a thyroid eye disease if the patient has got evidence of dysthyroid optic neuropathy, because this needs immediate treatment. You can start with steroids, and if the patient is not responding, you have to refer to a surgeon for the decompression surgery to save the optic nerve. Otherwise, the patient, it can land up in permanent loss of vision. So two life-threatening or emergency situations where you have to refer immediately are the corneal breakdown or a corneal ulceration due to exposure keratitis because of the lid retraction and exophthalmos. Then you have to immediately refer the patient because he can refer corneal abnormalities and loss of vision. And optic neuropathy, dysthyroid optic neuropathy, also you have to refer the patient. So you look for the, if the patient has got evidence of thyroid eye disease, look for the activity of the eye disease, okay, by looking at the eye for the retrobulbar pain, spontaneous retrobulbar pain, pain on eye movement, then the redness of the eyelid, redness of the conjunctiva, then swelling of the eyelid, swelling of the caruncle, swelling of the conjunctiva, and also ask the patient if he has any blurring of the vision. If the blurring of the vision is present, you look for the dysthyroid optic neuropathy by assessing the acuity of vision, color vision, and the ophthalmoscopy at the fundus, the disc for swelling. If the patient has got evidence of dysthyroid optic neuropathy, you have to immediately refer to the ophthalmologist, and CT orbit has to be included in the investigation because he may need a decompression surgery. And corneal breakdown also, you have to immediately refer the patient to the ophthalmologist. And if you suspect a dysthyroid optic neuropathy and you have confirmed by your clinical findings, then you can immediately start the patient on IV methylprednisolone for 3 days, 1 gram daily for 3 days. If no response after 1 to 2 weeks, then you should undergo surgical decompression. I-131 therapy causes progression of the ophthalmopathy in 15% of the cases. So if there is an active thyroid eye disease, then you think twice before referring the patient for I-131 ablation, because it can worsen the eye disease. Okay, and if you suspect and if you clinically you establish the diagnosis of dysthyroid optic neuropathy by the decreased acuity of vision, the disc chromatopsia and disc swelling, you start on steroids IV methylprednisolone for 3 days. If there is no response, within 2 weeks time, you refer the patient for surgical decompression. Risk factors for progression of the ophthalmopathy after I-131 therapy, one is cigarette smoking. So you make sure the patient stops smoking. okay, before sending for the patient for the I-131 therapy. Second, severe hyperthyroidism also can worsen the eye disease after I-131 therapy. So you try to control the hyperthyroidism with the medications as much as possible. Then if the patient has got a high level of TSH receptor antibody, which is characteristic of the Graves' disease, in that case also the patient can have worsening of the eye signs. And then you have done I-131 therapy, and if the patient is going for severe uncontrolled hypothyroidism, that can also worsen the eye signs. So that is why some of the physicians start immediately after the I-131 therapy, if he is not toxic, a small dose of L-troxin as early as possible for the first week or second week, without waiting for the hypothyroidism to develop. That will avoid the worsening of the eye signs. So cigarette smoking, severe hyperthyroidism before I-131 therapy, so you have to control it. High levels of TSH receptor antibodies, there you think that the patient may go for worsening of the eye signs, and an uncontrolled hypothyroidism after I-131 therapy can also worsen the eye disease. So high-risk patients, if you assess these high-risk patients, why do you want to know the high-risk patients? Because you want to take the prophylactic measures to reduce the worsening of the eye disease. If you are suspecting this patient to be high-risk patient, for example, he was smoking and his thyrotoxicosis is not well controlled, and then you want to send the patient for I-131 therapy, then you can start on prednisolone 0.5 milligram per kilogram 1 to 3 days after the therapy and continue on a tapering dose for 3 months. So you send the patient, this is a high-risk patient who can develop worsening of the eye disease after I-131 therapy. So you can send the patient for I-131 therapy, and after 3 days, you start on prednisolone 0.5 milligram per kilogram daily and continue on a tapering dose for 3 months. And also patients who are started on L-troxin 50 micrograms as early as 2 weeks after therapy have less progression of the eye disease. That's why some of the physicians, even without waiting to demonstrate that the patient has developed hypothyroidism, if he's a high-risk patient of worsening of the eye disease, better to start L-troxin after 2 weeks of I-131 therapy. Now, workup of a solitary thyroid nodule. When you see a solitary thyroid nodule, the high suspicion, if the patient has got a family history of medullary thyroid carcinoma or a family history of multiple endocrine neoplasia. So always you ask the patient in the history whether anybody had cancer thyroid in your family, whether you had a medullary carcinoma of the thyroid or multiple endocrine neoplasia. So you can actually roughly ask whether the patient has got a thyroid cancer in the family or any other cancers in the family for your immediate relatives. That is very important. And if the tumor is growing rapidly, if the swelling is rapidly growing, especially if on levothyroxine therapy, you have started L-troxin after seeing the thyroid swelling and it is rapidly improving, increasing in size, then also it is a high risk. And then a nodule that is very firm or very hard, okay, when you have palpated, the nodule is very hard, then function of the fixation of the nodule to the adjacent structures, paralysis of the vocal cords, the regional lymphadenopathy, distant metastasis, and all these will the high suspicion of a malignancy. So if you see that, the first thing is you do the ultra. If there is a high suspicion, then you always send the patient for surgery. If there is no high suspicion, there are no risk factors, then you can do an ultrasonographic examination and a fine needle aspiration cytology. Okay. If it is normal, then you can rule out. If it is follicular cells, then there is suspicion, because follicular cells cannot differentiate neoplasia from normal, benign condition. So either you send the patient for a thyroid scan and look whether the patient has got a functioning nodule or a non-functioning nodule, or you send the patient directly for surgery. Here I usually send the patient for surgery because there is a tension for the patient as well as the physician. A nodule, you have done an FNAC, the report has come as follicular cells, you are not sure whether it is a malignancy or a benign lesion. So the one option is you send the patient for thyroid scan and see whether there is any functioning, the nodule is functioning or not. Again, you will be in confusion. If there are small 2 nodules which are picked up non-functioning and this major one, the target one, is functioning, then still you are doubt whether it's a carcinoma or not. So it is better to send the patient for surgery, but that depends upon the patient decision and the physician decision, okay? And if the TSH is also elevated, high, then you know it is a hypofunctioning nodule. Then you look for the TFT and send for the thyroid scan and see whether the patient is, the TSH is suppressed. Suppose the TSH is suppressed, and then you don't know whether the patient is functioning or not, the nodule is functioning or not, send for the thyroid scan. These are the situations where you send for the thyroid scan and decide about the surgery of the thyroid nodule. Now comes the gynecomastia, workup of the gynecomastia. Sometimes you can get a patient with gynecomastia, that is unilateral swelling of a breast. You can get in an young patient. So how do you examine? How do you examine actually the gynecomastia? You have to always be very precise when you're examining for the gynecomastia. Just, yeah. Kai, you have to keep the hand behind the head. And then come like this. You keep the index finger and the thumb on either side of the nipple, and then just palpate and come closer and closer to the nipple area, and then you can, if you can feel a firm mount of rubbery tissue in between the finger, index finger and the thumb, which is concentric to the nipple areola complex, then that is characteristic of the gynecomastia. There will be a firm mount of rubbery tissue which is concentric to the nipple areola complex. That is the diagnosis of a gynecomastia. Okay? Suppose if it's a carcinoma of the breast, the swelling will be outside of the nipple areola complex, and you cannot feel a firm mount of rubbery tissue. So that is, you have to be very careful when you are examining for the gynecomastia. And gynecomastia, of course, you have to see whether you can rule out any testicular tumor by palpating the testicle for any testicular tumors. We are not going to palpate you. Testicular tumors, and then hypogonadism, primary and secondary hypogonadism, and also look for the secondary causes like liver disease, renal disease, etc., etc. And then, if you have ruled out all the secondary causes of gynecomastia in an elderly man or a young man, then you have to think of doing certain hormonal tests like the HCG, okay, one. Second is the luteinizing hormone, testosterone and estrogen. If the HCG is increased, it could be due to a testicular tumor secreting the human chorionic gonadotrophin. So you look for a mass in the testicle. If it is there, it is a germ cell tumor. Okay, what is germ cell tumor? Germ cell is what? What is germ cell tumor? Germ cell means it is the primitive cell from which the gametes are developed. The gametes, the sperm and the ova are developed from some primitive cells. No, those, if the tumor arising from the primitive cells which give rise to the gametes, the sperm and the ova, they are called the germ-line tumors. Germ-line mutation you have heard, no? Same thing, the germ cell tumors. So if there is a mass, you can suspect a testicular germ cell tumor which produces the HCG. Suppose if the testicle is normal, then you look for the extragonadal germ cell tumor. Again, extragonadal means not in the testicle. Outside of the testicle, the germ cells which are supposed to produce the gametes can produce a tumor. Okay, so that you look for, or HCG secreting non-trophoblastic tissue. Not the germ cells, the other cells are producing HCG. So for that, you have to do the chest X-ray and abdominal CT, looking for any malignancy which can produce the HCG secreting tumors. Okay? So that is one. HCG is increased, then you look at the testicle for the testicular mass. If there is no testicular mass, you suspect an extragonadal tumor, so you look for the chest and a CT abdomen. Suppose if the LH is increased and the testosterone is decreased, your concept is primary hypogonadism. The testicles are not working, so the testicles are not producing the testosterone, so the LH has gone up. So it is a primary hypogonadism. Suppose if the LH is normal and or decreased and the testosterone is decreased, both are decreased, okay, the LH is decreased, the testosterone is decreased, then you look for the prolactin. If the prolactin is high, then you know a prolactinoma is producing a hypogonadotropic hypogonadism. Okay, or if the prolactin is normal, it could be a secondary hypogonadism, secondary to an autoimmune hypophysitis, for example. Okay, so that is if both LH and FSH, LH and testosterone is decreased. Suppose if the LH is increased and the testosterone is increased, what happens? You measure for the TFT. In thyrotoxicosis, the sex hormone binding globulin will be reduced. It will be increased. Okay, will be increased. Here, what happens is the testosterone and estrogen both are there. The testosterone is more avidly bound to the sex hormone binding globulin, whereas the estrogen is not that avidly bound to the sex hormone binding globulin. In thyrotoxicosis, what happens? The sex hormone binding globulin is increased. So whenever the sex hormone binding globulin is increased, testosterone will be more and more will be attached to that. The sex hormone binding globulin bound testosterone is inactive. The functionally active testosterone is the free testosterone and the albumin bound testosterone. That's called the bioavailable testosterone. Okay, so that will be proportionately reduced if the sex hormone binding globulin is increased, and the relative proportion of the free estrogen will increase. So that produces the gynecomastia in a case of thyrotoxicosis. Suppose, if the thyroid function is normal, then it could be androgen insensitivity. What happens here? The androgen receptors are not functioning properly. The androgen is binding to the receptor, but the downward signaling pathway is not effective. So the patient will have increased LH and increased testosterone. That is called androgen insensitivity. Okay. Suppose if the luteinizing hormone is normal or decreased and increased estradiol, okay, estrogen is increased and the LH is normal or decreased, then you have to think of a testicular tumor and look for the Leydig cell or Sertoli cell tumor which produces the estrogen, and if it is normal, then you look for the adrenal neoplasms which can convert the adrenal androgens to estrogens, and if that is also normal, then you can think of increased aromatase activity, because the aromatase complex of the enzymes are the ones which convert the adrenal androgens into estrogens. So if there is an increased aromatase complex activity in a person, that will increase, there will be increased conversion of estrogen from the adrenal androgens, and that produces the gynecomastia. And so this will be, because this will be, the other investigations will be normal. And if all these are ruled out, then idiopathic gynecomastia. And most of the cases, it will be an idiopathic gynecomastia. So you can do the basic test, HCG, testosterone, LH, and estrogen. Depending upon this, you can detect what could be the cause of the gynecomastia. If nothing is found out, then, so the first task is to look for the secondary causes of gynecomastia. Drug ingestion, for example, cimetidine, spironolactone, digoxin, all these drugs can produce gynecomastia. Or look for evident causes like thyrotoxicosis, liver failure, respiratory failure, etc., etc. Or if there is any definite history of primary or secondary hypogonadism, and rule out all the secondary causes and then look for these tests, HCG and then testosterone, LH and estrogen, and from this you can deduct and come to a final diagnosis whether the patient has got idiopathic gynecomastia. Now, another situation which you get in your in station 2 is the IBS. So you should always remember irritable bowel syndrome, the criteria, the ROMS criteria, okay? The recurrent abdominal pain or discomfort at least 3 days per month for the past 3 months. In the history, when you are eliciting, if the patient is coming with abdominal pain and diarrhea, to rule out an IBS, try to take this history. How many months you are having this diarrhea or abdominal pain, and how many days in a month, and how many months previously you have this. So the patient should have at least 3 days in a month for at least 3 months with 2 or more of the following. 1, improvement with the defecation. I have abdominal pain, but when you go to the toilet, I get relief. That is improvement with the defecation. Onset associated with changes in the frequency of the stool. I have abdominal pain and I have diarrhea together, or change in the form of the stool. I was passing normal stool, but now my stool is becoming a little bit oily because the consistency has changed. So 2 of these plus the abdominal pain relieved of the defecation should be there to make a diagnosis of IBS. So there are different types of IBS. Irritable bowel syndrome with the constipation, which is more common in women, IBS with the diarrhea, which is common in men, and IBS with the mixed bowel habits. Okay, these are the 3 types of irritable bowel syndrome you can get. The warning signs, always take a history of warning signs in IBS. Whether the patient has got any rectal bleeding, whether a history of an anemia, whether any weight loss, any fever, any family history of a colon cancer, especially in young people. The onset of the IBS after the age of 50 years, always suspect. It could be a warning sign. Major change in the symptoms, very severe changes in the symptoms, also a warning sign for that you have to look for a malignancy. Differential diagnosis of the IBS, functional abdominal pain syndrome. But functional abdominal pain syndrome, there will be no change in the bowel habits. Bowel movements will be normal. Chronic functional constipation, there will not be any pain. Chronic functional diarrhea, there will not be any pain. Celiac disease sometimes can simulate a IBS. Microscopic and collagenous colitis can also mimic an IBS. And atypical Crohn's disease sometimes can mimic a IBS. So these 3 important diseases you have to keep in mind when you are taking a patient with a history of IBS. Celiac disease, then microscopic and collagenous colitis, where you need a colonoscopy and biopsy and histopathological examination, and atypical Crohn's disease. So these are the differential diagnoses which you have to think of when you come across a patient with irritable bowel syndrome. Usually, the IBS symptoms are preceded by a major stressor or a physical stress, either a gastrointestinal infection or a major illness. And IBS is often described as a brain-gut disorder. There is a brain-gut disorder, alterations in the gastrointestinal motility and in the balance of absorption and secretion in the intestines may underlie the irregularities in the bowel habits. Increased perception of the visceral stimuli may contribute to the symptoms of abdominal pain and discomfort. Alterations in the immune activation of the mucosa and in the intestinal microflora may also contribute to the symptoms. So after detailed history taking, accept the patient's symptoms of distress as real and not simply as a manifestation of excessive worrying and somatization. So you should not tell the IBS patient that this is only your worry and your somatization, nothing to worry. But you sit with the patient and accept your symptoms are real, and this is defined as a brain-gut disorder because there is some abnormality of the brain control of the intestinal movement, and there is also some abnormality of the intestinal absorption and secretion. That is why this happens, madam. We can try to treat you and we can try to solve your problems and provide all the plausible models of the disease, explain to the patient the possible model of the disease as a brain-gut disorder, and that facilitates a positive patient-doctor relationship. Just ignore the patient and say this is all somatization symptoms, nothing to worry. You are thinking too much, that's why you are getting IBS. The patient will not have confidence in you. To create a rapport with the patient, better to say that the symptoms are real and this is called a brain-gut disorder, and there are treatment options for you to be cured or to be under control. Acknowledge the disease, okay, and educate the patient about the disease and reassure the patient. This will improve the outcome. You have to acknowledge the disease, educate the patient about the IBS, and reassure the patient, and then the disease will cure. Explain the patient regarding the cognitive behavioral therapy, which is an addition to the medical therapy. So cognitive behavioral therapy, cognitive combination of the behavioral and cognitive techniques best studied by psychological treatment. That is the best treatment for the IBS. Cognitive behavioral therapy. Cognitive techniques are administered in a group of an individual format in 4 to 15 sessions. Cognitive techniques are aimed at changing the catastrophic or malabsorptive thinking patterns underlying the perception of the somatic symptoms. So you try to change the maladaptive thinking patterns underlying the somatic symptoms. That is cognitive techniques. Behavioral techniques are aimed to modify the dysfunctional behavior through relaxation techniques, contingency management, rewarding healthy behaviors, and assertion training. This is called cognitive behavioral therapy. But if you get the IBS patients, we remember that to say that this is a real, acknowledge the patient disease and explain to her the brain-gut disorder and all modalities of treatment, including the cognitive behavioral therapy. Now, pulmonary rehabilitation in COPD is also an important topic. The COPD has got, all of you know, the COPD has got extra pulmonary manifestations, and chief among them is the skeletal muscle dysfunction, especially the leg muscles, because there is an atrophy of the aerobic type 1 fibers in the leg muscle, because the chronic obstructive pulmonary disease patient become lethargic and sedentary. So there will be an atrophy of the type 1 fibers in the calf muscles. So that produces more of disability than the respiratory discomfort in COPD. So what happens when the leg muscles are fatigued very fast? That reduced aerobic capacity manifested as early lactic acidosis. So when the patient starts moving, there will be reduced type 1 fiber activity in the leg muscle, so that will produce lactic acidosis. Lactic acidosis will further increase the respiratory rate, so the expiratory time will be reduced, and then further hyperinflation will occur, and the patient's COPD will become worse. So muscle fatigue rather than dyspnea is the primary factor limiting the exercise tolerance in COPD. So you should always remember, it is not the dyspnea part which is restricting the activity, but the muscle fatigue, especially the leg muscle fatigue, which is restricting the patient's mobility. So exercise program is the centerpiece of pulmonary rehabilitation. It's not a respiratory physiotherapy. The exercise program is the centerpiece of the pulmonary rehabilitation. There are individually tailored exercise programs delivered under direct supervision as 3 sessions per week for 3 months, 3 to 4 hours every day. That is the usual program in pulmonary rehabilitation, and that will be followed by maintenance programs at home. There are 2 types of exercises, endurance exercises and resistance exercises, okay? Endurance exercises of the leg muscle is the main focus. This is carried out by treadmill, walking and stationary cycling, and high intensity regimes are usually preferred than the lower intensity regimes. Exercise intensity is increased as tolerated. So exercise is the main program in pulmonary rehabilitation. The endurance exercises are more important than the resistance exercises, but you can add resistance exercises also. Resistance exercise is also included that improves the lung strength, so that helps in the activities of daily living. And if you improve the upper muscles, some of the upper limb muscles like the trapezius muscles are auxiliary muscles of respiration, which can help in the respiration also. So you can include both endurance and resistance, but endurance is more important than the resistance exercises. Along that, you educate the patient regarding the type of the disease and the importance of stopping smoking, and the importance of incorporation of exercise and increased physical activity at home. You should not be sedentary at home, you should start moving around. Importance of adherence to therapy, and also an action plan for earlier detection and treatment of exacerbations, and the self-management strategy has to be drawn out, and many programs include also a psychosocial component. This is the picture which shows you that the exercises, the central desensitization of the dyspnea. There is a deconditioning occurs in COPD, so that is why with each movement the patient becomes dyspneic. So there will be a central desensitization occurs as a part of the exercise program. 1. Second, that decreases the anxiety and depression. Most of these patients are depressed and anxious, and when exercise you are doing, there's a lot of dopamine and neurotransmitters are released, endorphins are released, so that will allay the anxiety and depression and reduces the hyperdynamic inflation. What is dynamic inflation? In COPD, the expiratory time is reduced, so there is, during the end expiration, there is trapping of air in the alveoli. Okay, for that, if the expiratory time is increased, the pursing of the lips is done to increase the expiratory time to breathe out as much air as possible. a patient with a COPD, when he starts walking, the exercise, the muscles are fatigued, so naturally the work of breathing increases and the respiratory rate increases. When the respiratory rate increases, what will happen? The expiratory time is reduced. When the expiratory time is reduced, means more of air trapping occurs in the alveoli. When this air trapping occurs, what will happen? The end expiratory volume, the lung capacity or lung volume increases. That leads to increase in the end inspiratory volume. When the end inspiratory volume becomes almost equal to the total lung capacity, the limiting volume, the work of breathing increases. And that produces more fatigue and more dyspnea. So that happens with exercise. What will happen? The patient will get used to the increased respiratory rate. The respiratory rate will come down. With regular exercise, the increase in the respiratory rate will slowly will come down. So the patient will get enough time for expiration and the dynamic hyperinflation will be reduced. So if you don't do the exercise, if you are sedentary life at home, when you start walking, the respiratory rate will increase. And so that will reduce the expiratory time. So that will increase the trapping of the lung, and the lung volume will increase. That will almost reach the total lung capacity, and then patient will become dyspneic even at rest with minimal exertion. But when you do exercise, what will happen? That will train you, and that will slowly reduce the increase in the respiratory rate, and that will avoid the dynamic hyperinflation and then improve the skeletal muscle performance. Of course, the type 1 fibers will more and more will get activated, so that will improve the skeletal muscle performance. So this is what in pulmonary rehabilitation you are doing. Now comes the workup of the adrenal incidentoloma. You can get a patient in station 4, a station 2 history taking patient, where the patient has undergone a ultrasonography of the abdomen and found adrenal swelling. What test you have to do? You have to suspect a Cushing's disease 1. Second is the pheochromocytoma and the primary aldosteronism. These are the 3 which you have to suspect, and then of course malignancy. The subclinical Cushing syndrome, you have to do the basic screening, the urine 24 hours cortisol or the midnight salivary sample, and then dexamethasone suppression test. For the pheochromocytoma, you do the 24 hours urinary catecholamines and fractionated metanephrines and nephrines. And then primary aldosteronism, you look for the aldosterone and renin ratio, and then you do the saline suppression test. Okay, this is a flow chart which tells how to go ahead with the adrenal adenoma. Then workup of chronic daily headache. Actually, you can get a patient with a chronic daily headache. When you label a patient as a chronic daily headache, when the patient is getting headache for more than 15 days in a month, it is called a chronic daily headache. Okay. So in the history, always you ask the patient whether you had episodic migraine in the past. Episodic migraine means the unilateral headache, which is pulsatile in character, severe pain, usually retrobulbar pain, sometimes or most of them associated with nausea, vomiting, photophobia, phonophobia. These are the characteristics of episodic migraine. If the patient had episodic migraine in the past and now of late he is getting more than 15 days in a month, you can suspect a transformed migraine or a chronic migraine, okay, transformed migraine. And then always in the history you ask for a medication overuse headache. Patient has episodic migraine or headache and patient is taking a lot of analgesics that will worsen the headache. That is called the medication overuse headache. So always try to rule out the possibility of a medication overuse headache in the history, and then look for the secondary causes of the headache like cervical spondylosis, intracranial hypertension, space occupying lesion, intracranial hypotension, infections, etc., etc. You have to rule out and then come to the differential diagnosis of a chronic daily headache. If the headache is lasting for more than 4 hours, then the differential diagnosis is very narrowed down. It could be a chronic transformed migraine. It could be a chronic tension headache. It could be a cluster headache, or it could be a hemicrania continua. These are the 4 types of headache which can occur more than 4 hours. If the duration of the headache is less than 4 hours, it could be either a hypnic headache. Sorry, if the headache lasts for more than 4 hours, It could be transformed migraine, it could be chronic tension headache, or it could be a new onset persistent headache. That is, a woman had a lower upper respiratory infection in the past, and following that, she is having continuous headache for more than 15 days in a month. That is called a new onset persistent headache. And then comes the hemicrania continua. These are the four which, if the patient has got more than 4 hours, if the patient has less than 4 hours, then it could be a cluster headache, it could be a hypnic headache, it could be a paroxysmal hemicrania, or a neuralgiform headache. Okay, these are the 4 differential diagnoses if the patient has got a less than 4 hours. So just ask the history of autonomic symptoms along with the headache, so that if the autonomic symptoms are there, it goes in favor of a cluster headache, or a paroxysmal hemicrania, or a neuralgiform headache. Then workup of the vitiligo. Vitiligo you can get as a case in station 5. So there are 2 types of vitiligo, segmental vitiligo and non-segmental vitiligo. Segmental vitiligo usually occurs in children. It is not autoimmune, and the margins will be well demarcated. There is no Koebner's phenomena in segmental vitiligo. Koebner's phenomena means a disease-specific response to a non-specific stimulus. That will not be there in segmental vitiligo, and it usually confined to one dermatome. Okay, it will not be usually bilaterally symmetrical, usually confined to one dermatome. And the treatment of autotransplantation is effective in segmental vitiligo because there is no Koebner's phenomena. Whereas the non-segmental vitiligo is usually starts in adulthood. It can have flares and progress. It can progress with the flares and remissions, and it always it involves the hair compartment at a later stage. Okay, and it's also associated with the autoimmune diseases, especially thyroid autoimmune disease, and commonly occurs at the sites subjected to friction, like at the strap of the watch, or at the brazier site, or the underwire. These are the sites which are affected by the site because of the Koebner's phenomena. When the friction is there, there is a disease-specific response to that friction that produces the vitiligo changes in that part, and frequently the relapses in situ after autologous grafting, because any Koebner's phenomena, any trauma can precipitate the lesion there, because there will be recruitment of the T lymphocytes at the same type of injury and can produce this sort of a picture. So that is called non-segmental vitiligo. If you get a non-segmental vitiligo patient, you always think of the possibility of autoimmune diseases and also thyroid disease, which you have to rule out. This is the picture which shows where else you can get the non-segmental vitiligo. All the pressure areas can be affected. And this is a non-segmental vitiligo, and this is a segmental vitiligo. You can see one segment, one dermatome of the body is affected. And certain differential diagnoses you can think of when you see a patient with a vitiligo. For example, inherited or genetically induced hypomelanosis, like palbaldism, tuberous sclerosis, where you can get hypomelanotic macules, which can be confused with the vitiligo. Second is a post-inflammatory hypopigmentation, which can occur in psoriasis and lichen planus, etc. Then paramalignant hypomelanosis, which can occur in mycosis fungoides and melanomas. And then para-infectious hypopigmentation, which can occur in tinea versicolor and recalcitrant pityriasis rosea, which you can see in young people at the lower back. You can see some hypopigmented patches, which is due to the propionibacterium infection. Okay, that is called recalcitrant pityriasis rosea. And then acquired macula, that is one. Then post-traumatic scleroderma. Some people have trauma and then there will be white vitiligo changes. That is called post-traumatic vitiligo or leukoderma. Then occupational, of course, occupational exposure also can produce vitiligo. And drug-induced vitiligo, 2 drugs you always think, chloroquine and imatinib. Imatinib mesylate is used for chronic myeloleukemia treatment. These 2 drugs can produce vitiligo. You can see a lot of people on imatinib becomes very fair. There is one staff here who was very dark, but now she has become very, very, very fair, fairer than Dr. Musab, because of the imatinib that produces a depigmentation. Okay, so certain differential diagnosis you should have. Even vitiligo patients, we will ask for a differential diagnosis. So you should think of a few differential diagnoses you should be able to tell us. It could be inherited, like palbaldism and tuberous sclerosis. or it could be a post-inflammatory, or it could be a para-infectious, or it could be a para-infectious or para-malignant, and then post-traumatic, occupational, and drug-induced. These are the things which you should remember when you see a differential diagnosis of the vitiligo. Thank you very much.